Hello, my name is Umair Khalid. I'm one of the social media editors at JACC Cardiovascular Interventions, and it is my great pleasure to welcome Dr. Rodriguez Leor today. Dr. Rodriguez, thank you for taking out time from your schedule and joining us today for this interview.
Thank you, Dr. Khalid. It's a great pleasure for me to be here today.
Likewise, great to have you, sir. So today we will be featuring your article titled A Prospective Multi-Center Real-World Registry of Coronary Lithotripsy in Calcified Coronary Arteries from the Replica EPIC 18 study. So if you could first briefly tell us about the design of the Replica EPIC 18 study for the audience who may not be familiar with it.
Yes, of course. Well, the Replica EPIC 18 trial was a prospective multi-center, single-arm, open-label, and all-comers that we conducted in 26 hospitals in Spain. So the main objective was to assess the effectiveness and safety of the IVL balloon to treat calcified coronary lesions in real-life patients, because we had wrong information coming from different previous trials, but that enrolled, let's say, some kind of selected patients and lesions also treated. So our intention was to verify if the results that were observed in the previous trials were the same in a real life population. So, for example, I'm referring to the DisruptCat trials, and patients with acute coronary syndrome were not enrolled in those trials, and in Replica represent more than 60% of the patients. And also regarding the characteristics of the lesions, for example, in the previous studies, there were not total chronic occlusions, no left main that, for example, in our registry were more than 11%, no lesions in bifurcation, and also there were no previous use of the bulky techniques such as rotablator, orbital atherectomy, laser, etc. So our intention was just to show if the results in terms of safety and effectiveness were the same.
Thank you, Dr. Rodriguez Leo. That's very helpful for me. So I saw two key endpoints in the analysis. One was primary effectiveness endpoint, and the other was the primary safety endpoint. Could you very briefly describe their definitions?
Yeah, regarding the primary efficacy criteria, it was defined as procedural success. And we defined procedural success as a successful delivery of the IVL therapy. So the catheter needed to cross the lesion and deliver the energy just to break the calcified plaque. We also defined it as a final instant stenosis of 20% or less after IVL and stent implantation, and also no in-hospital complications. So it was in this sense, this was the definition of procedural success. And regarding the safety, we looked at the 30 days clinical outcomes, and we look at the MACE incidence, and we define MACE as cardiovascular death, myocardial infarction, or need to target vessel revascularization. So all clinical events were reviewed and adjudicated by an independent clinical events committee, and I think that this is also important to consider.
Absolutely. Thank you for your response, Dr. Rodriguez Leo. As you briefly mentioned in the start also, IVL use for coronaries has been rapidly expanding. Every year, more and more operators are using it. Some may think that it's actually safer, maybe faster than some of the other calcium modification techniques that we have, and we can use for double wire and all those things as well. So in your analysis, primary effectiveness endpoint was met in 66% of the patients. So I was curious why in the other 34% of the patients, what were the reasons behind the failure to meet the primary endpoint of effectiveness?
Yeah, we have to consider that patients and also lesions in replica were quite complex. And in fact, up to 49% of lesions were considered undilatable lesions. So our definition for undilatable lesions were when it was not possible to cross with a conventional balloon, and the use of a debulking plug technique was needed, such as rotablator or orbital atherectomy or laser, or when adequate expansion was not achieved with a non-compliant balloon up to 18 atmospheres. So taking this into account, the crossing rate was very high. And in fact, there were only 3 patients where we could not cross with the balloon. So this was not the main issue. In hospital, MACE was also very low. And the main issue was the angiographic result. So we defined angiographic result as a final in-stent stenosis of 20% or less. And this was achieved only in 70% of our patients. And probably this was due to the characteristics of the lesion that, as I mentioned, were quite complex. So if we look at data from previous studies, like the DISRUPT-CAT3 trial, so there the angiographic success was defined as a final stenosis of 30% or less. So in our population, that was achieved in more than 80% of patients. So that gives us an idea of the complexity of the lesions that we treat.
Absolutely. Thank you. That really helps clarify a lot of things. So it's great to know that most of the patient, almost all the patients, had good deliverability and good in hospital, very low in hospital base. And the lesion complexity was the reason behind the angiographic part of the outcome. So thank you, Dr. Rodriguez-Leor. And lastly, could you please describe the results of your primary safety endpoint, and including the differences between ACS and CCS patients?
Yeah, procedure-related complications were really very, very low. So in fact, we only had 1 case of coronary occlusion, 3 cases of coronary perforation that were resolved implanting a regular stent, and 10 cases of coronary dissection. There were no cardiac tamponade, no stroke, and no death related to the procedure. So in terms of safety of the procedure, the results were really encouraging, considering also, as I mentioned, the high-risk population and high-risk lesions that we were treating. Regarding in-hospital MACE, there were also only 8 cases of MACE, 1 case of cardiovascular death, 6 cases of myocardial infarction, 4 were directly related to the procedure, and only 1 case of TBR. So there were really a very low complication rates at hospitalization. And if we look at 30 days MACE, occurred in 15 patients, which represents less than 4% of the global population. And when we compared patients with chronic coronary syndromes and acute coronary syndromes, there was a trend to a higher incidence of MACE in patients with acute coronary syndrome, as it seems logical, but it didn't reach statistical signification. So it seems that the use of IVL balloon in a real life setting, complex population, very complex lesions, was safe in terms of the procedural results, and also at 30 days clinical follow-up.
Thank you, Dr. Rodriguez-Leor. It's great to see this study confirming the safety aspect of IVL in a real world setting. And IVL, as you know, is still relatively a newer technique compared to rotablation and CSI and other modalities. Thank you so much for sharing your insights with us, and congratulations on your work.
Thank you very much.